It's my pleasure to welcome everyone back to the fourth lecture in our series. Today we will learn from Drs. Barbara Anderek and Heather Fair. Dr. Anderek is the Jacob S. Zook Professor of Physics and Astronomy and is a consultant evaluator for the Higher Learning Commission. She is the former Associate Dean of Academic Affairs responsible for OWU's assessment and accreditation, and she remains our resident expert on time. Dr. Fair is an instructor in botany microbiology. She's a recent recipient of a 3-year National Science Foundation postdoctoral fellowship in biology. She'll be working with the Chinese Academy of Sciences, U.S. Department of Agriculture, and University of Minnesota to increase participation of deaf and hard of hearing people in science and examine invertebrate and microbial communities of mountain glaciers in the Tibetan autonomous areas of China. Today's presentation will be about 55 minutes long, and then we'll take a few questions. As a reminder, you can use the chat function to ask questions throughout the presentation. I will select a few for our panelists to answer. You can also continue your discussions on the COVID-19 course Facebook group. And now, modeling COVID-19.
Thank you very much. Appreciate that, Kira. First, let me say that it's been delightful to work on this project because I got to meet a new colleague, even though I had to meet her remotely, and that's Heather Fair, who's going to be doing part of this presentation. And I also got to learn a lot of new things, got to practice those lifelong learning skills that we so value in higher education. As Kira pointed out, I have had a number of roles. I'm a physicist, specifically I'm a condensed matter theorist by training. I am a faculty member, I have been an administrator, but the role that I value the most is one of educator. And so I had to do a little educating of myself for this project. I came at this as a physicist, and so let me explain that physics likes puzzles, and we like to view things from as foundational a perspective as we can. In fact, Einstein said everything should be made as simple as possible and no simpler. So that's kind of the approach to COVID. I was pleased as I was doing some of my research to find that one of the people who is cited for the foundational work on modeling of epidemics and infectious diseases was a physicist, Robert May. Unfortunately, because I don't have access to our libraries and all of the journals, in the same way if they're not online, I couldn't see some of the papers that he'd written, but at least I know that that foundational principle of making things simple was underlying this. There's some challenges when you're trying to learn about a new field, especially if you don't have somebody there to mentor you. One of the challenges is that all the disciplines kind of speak a different language. So I'm used to thinking about things with one set of terms and words and ways of constructing the knowledge, and that may differ for other fields. And the other is that not everybody comes at things at the same starting point. And so those were some of the challenges. I'm going to try to share with you a little bit about what I've learned about the way in which modeling is done and how we might think about that, maybe even some lessons from how we learned things in our undergraduate or even pre-college days that are useful to this. So we'll start with something that you're very familiar with, a curve that you've seen a lot. And that is this notion of flattening the curve. So this is one of the first things we heard as we all went into quarantine. The reason we were doing that is because we needed to lower the peak of this curve in an attempt to bring the maximum infections that were being dealt with on a daily basis below what our healthcare system was able to deal with. By the way, this curve dressed in Bishop's Spirit Day. That's the best it could do with red and black, but it's there. Okay, but what do these curves mean? So, and where did they come from, and where did this warning come from? As best I can tell, the initial predictions that led to this notion of let's flatten the curve or we're going to have some real problems came from mathematical epidemiologists at the Imperial College of London. And they had these graphs that were published in Nature that showed what the death rate per population was going to be per day through this period that ran from March through to July. And if nothing was done, their predictions were that the United States would have 2.2 million deaths and the United Kingdom would have 500,000 deaths. And so that was the impetus for fairly swift interventions that we've seen and we've been following, actually. But the question is, from this graph that we see here, how do we get from that to the predictions that they show, the numbers that they show? Because what we have plotted here are the number of deaths per day per 100,000 population. So the first thing that would have to be done with this is it would have to be scaled up so that it corresponds to the total population of the UK and the US. So US population is 330 million, and the UK population, I think, is about 67 million. So you would have to scale this up by the appropriate factor to bring it to that population. But that would still just give you the daily death rate. If we want to see what the cumulative death rate is, then we need a different curve, another curve. And so what I have put here is the grayish blue curve is to represent those curves that were on the previous page, and those would indicate something about the number of deaths per day. But if we want to find out the total number of deaths over this time period, we have to add up the number of people that die on any given day. And so if you've done some mathematics, you know if we add up all of these little pieces per day, that's finding the area under this grayish curve or integrating. And so that's what the red line represents. That represents the total number of deaths. Don't pay any attention to the actual number of deaths shown in the scale. This is clearly much less than what I was talking about in the previous graph or previous slide, but this is just to illustrate what's going on. Also, I had to increase the scale for the daily rate by a factor of 20, or it would have been buried down at the bottom and you wouldn't have been able to tell much about it. So that's one of the things that we can learn about from these kinds of graphs. But often you will see them presented in different ways. So on this next slide, I've taken that total number of deaths and I've presented it in two different ways. So on the left is the number of deaths the way it was presented before, where the y-axis, the vertical axis, is just a linear axis. But on the right, I have the same numbers, but what we've got here is a logarithmic scale. So we've changed the way in which the graph is presented. We've stretched and changed it. And as a consequence, it has a very different look to it. And there's a very different point at which, or so it appears, at which this inflection point that I had on the previous slide shows up. So the inflection point is the place where the curve on the left kind of turns and changes its slope. And on the right, it doesn't appear to be anything in particular, right? But it's at the same day, at that day 50. That inflection point is a key point because that's where the peak in the curves, the cases per day is. That's where things turn over. So we'll talk a little more about that in a minute. But you have to watch when you're looking at graphs, what's being plotted and on what kind of axes is it being plotted. So let's look at some predictions beyond the one that that got us started on the social distancing that we've been doing. Some predictions that came fairly early on. Well, maybe not so early on, but for different states in the United States. And I could have found more recent data, but I kept these data because they illustrated some things that I thought were important. It's one of the challenges when you're dealing with these kinds of models. And so if you look and see for the case of Michigan, there are about 6 different models, and they all are following a fairly similar trend. These are the number of deaths. So to the left, the green points are actual data. Those are deaths leading up to this particular time. And then there are these models that are saying, and where are we going to go from here? Right? So those seem to be in pretty good agreement. But if you look over on the right side and you look at Ohio's predictions, same groups making these sets of predictions, you see that they vary widely for Ohio. Now, Some of these are done by different groups that come at the study in a different way. And some of these are done by the same group with different assumptions. And one of the reasons that Ohio has such drastically different cases is because these predictions came right after the outbreak at the Marion Correctional Institute facility. And so there had been a large number of cases just a few days before this prediction came out. And if you're using recent jumps in numbers of cases and you're relying on that heavily, if it's a factor that influences your model significantly, you're going to get a much higher death rate following that. And of course, if you're not, it's hard to put into a model lots of details like, oh, well, maybe those people at the Marion Correctional Facility, maybe they're of a younger age group than if we had them in a nursing home. Maybe they're in better physical shape. Maybe they were infected so readily because of their proximity to each other. None of that can appear in these models that are simpler. And so we get this wide variation depending upon how the data are used as inputs. And another more extreme example, I suppose, or another one with some caution, is the state of Wyoming, where, on the next slide, where the number of cases that they had to extrapolate from were 3 deaths prior to this, the predictions. So if you've only got 3 cases, it's very hard to have much in the way of a trend. So as a consequence, the models don't have too much to go on. And so it's very dangerous if you try extrapolating really early in the process. The more data you have, the better, the more reliable it is, the more robust it is, the better your predictions can be. And then the next slide, we have some forecasts for deaths in the United States in general. So this is from a few days ago. And I picked this because the models are predicting such radically different behaviors going forward. In fact, now part of it may be when the models were put together and the New York Times just pulled together models that were done by different groups. But you'll see that the Imperial College was being very pessimistic about things. In fact, their prediction had the death rate in the United States much higher than what it actually was at the time the report was put forward. Whereas Northeastern rather, was incredibly optimistic down here in the purple. So not clear why that is. This is all to show that while all of these groups were doing very reliable, very robust kinds of predictions, there are a lot of different ways to come at what's going to happen. And it depends upon the data that you're putting in, as well as the kind of model that you're using. So it's very challenging to try to figure out, where do we go from here? What are things going to look like? And so, yeah, it would be nice to know, but we don't. So here's a very basic concept that's involved one way or the other in almost any of these models or any of the representations of just actual data that we see. So we'll talk about this and then its relative in just a minute. So this R0 is called the basic reproductive ratio. Sometimes it's called the basic reproductive number. And it says if you have an infected person, the person in red here, how many other people is that person going to infect on average, right? So for the particular picture we have here, R0 is 2 because our infected person is going to infect 2 other people, and each of those people is in turn going to infect 2, and so on. And so that is a way in which we get this exponential growth that happens when we have an epidemic. But if we move on and think about it, then under what conditions will we have an epidemic? That is, what does R0 have to be to have an epidemic? Well, it needs to be greater than 1. If the person that's infected is not likely to infect another person. If on average, an infected person is going to infect less than one other person, then the disease will die out gradually. On the other hand, if R naught is greater than 1, then we're going to have more and more people that are infected, and that's when we have an epidemic. Now, the way that R naught was defined in the previous slide indicates that mathematically that R naught is going to be the base of this exponential growth. And so that R naught is going to get raised to a power that says how long do we have to wait in order to see this reproduction, factor of 2 for the last slide, but it could be 3 or 4 or 5, depending on what R naught is. L is the infectious period. We don't know that really well for COVID-19. CDC says somewhere between 2 and 14 days. So if you wait that 2 to 14 days, and that's your time period T, and you raise R naught to that power, then you will see how many people are infected at that point. Now, how do we know what R naught is? Well, we can come up with a fairly simple kind of way to put some pieces together to try to say what it might be. If we want the actual value of R naught meaning what R was at the beginning of the whole infection process, then we have to work backwards from actual data. But if we want an estimate of it, there are 3 pieces, contributors to that R naught. One is the number of susceptible individuals that our infected person is going to encounter in a day. That's S. Then we have to know what's the probability for those people that our infected person is going to encounter. What's the probability of transmission of the disease to the people that he or she encounters? And finally, how many days are these infections likely to be transmitted? So that's L, this infectious period. Sometimes these first 2, the S and the beta, have a slightly different feel to them. At least that's the sense I get in reading. Sometimes S is like the total population that could be infected, and then the transmission rate isn't per encounter, but it's rather the overall transmission rate to that population. So I do think different people are using that in slightly different ways. Now, a lot of times R naught is the term that's used when that's not really the correct terminology, because R naught really only applies at the beginning of an epidemic when the entire population is susceptible. If we're talking about what R is now, we really ought to say R sub T or just R, because that's the effective reproductive ratio at this point in time. Right now, how many people is an infected person likely to infect? And it's going to change either because of interventions or because of the fact that some of the population has already had the disease and may not be susceptible anymore. We don't know that very well, do we? This R sub T value or R value uses the actual data that we have to date based on what we get from the clinics where they've been doing the tests. And those are used then to try to predict what that effective reproductive ratio looks like. And it's what we start to see affecting the curves that we have. I will say that in listening to the BBC broadcast, often in the UK, they are talking about this R value. They seem to understand what it means because their goal is to get it to be less than 1 so that we're no longer in this epidemic situation. And so we don't hear about it as much, I don't think, on US media. Now, this R sub T, or just R, this reproductive ratio, effective reproductive ratio, can be reduced, as we know. That's the reason we've been in the situations we have for the last 6 weeks. And a lot of times that reduction comes by reducing S, the number of possible encounters of the infected person with susceptible individuals. And so the particular interventions that we see listed here, again, this comes from the Imperial College folks when they were trying to say, here's what probably should be done. You'll see that that's cutting down on the effective R value. So what's on this vertical axis is what is the R value at a given time. And we can bring that R value down closer to 1, our goal here, if we put in place these isolation measures. Now, you can also reduce the effective R by reducing beta, the probability of transmission. But you do that if you're using PPE, you're using your own personal masks, you're washing your hands effectively. So those are ways to not reduce the number of encounters, but the probability of an infection if you've had an encounter. Right. So those are some sort of basic terminology and some ideas about how to view the models. But there are a lot of complications, and we'll hear a little bit more about that as we learn about Heather Fair's journey into this this whole area. So I'll pass it over to Heather.
Thank you, Barbara. That was very nice. A nice introduction to the modeling and some of the background calculations. So I'm going to talk a little bit about the models, but first of all, tell you that I'm an ecologist, so I'm not an epidemiologist. So again, like Barbara, I've picked up a lot from teaching this semester. And my experience with this whole epidemic actually started maybe much earlier than most of us, that probably remember about mid-March when the Arnold Schwarzenegger competition was put on hold. That was late for me. So my experience actually began in January when I was hired a second year to go to teach in China with the Middlebury School of the Environment. And so about January 29th, we were getting some communications. We were starting to plan our courses, and we actually got a communication that said, hey, there's this virus in China. We're concerned about the health and safety of the students traveling and all this. And I thought, oh yeah, but that's June. I mean, that's fine. That's several months away. We'll be way beyond that, because I'm thinking of the first SARS in about 2004 it was that we went through. And I was in China as soon as the travel ban was lifted. It didn't take long at all. So it was kind of a surprise to me then, very soon after, on about February 4th, to find out that my summer teaching job #1 was canceled. And then I had a further job opportunity with Duke University, but then that program was canceled as well because it was a field school as well. So just something kind of interesting. So then we went on this lockdown, which was, you know, a good decision. And then I was trying to figure out, well, how do I go do this grocery shopping? I waited like 2 or 3 weeks before I ventured outside. And then I went down the basement because I remembered from my many years of travel to Asia, I had a collection of masks. So no, after I posted this, people were like, oh, Heather, you're a great sewer. I said, no, I don't make these masks. I've actually collected them over many years, and now's maybe the first chance I've had to use them, except for running in the cold. You know, I wore a mask, but at that time, it was about March 26th. We really hadn't been talking about masks in the US. In fact, I was kind of nervous about wearing mine and going to Aldi and Kroger and all that to go shopping. So I actually taped a sign on my back and I said, hey, you know, I'm healthy. You know, I just want to do this out of respect for you and your family, that I may be asymptomatic and shedding my virus. You know, at that time, let's just all wear a mask and beat this together. So anyway, there was a lot of mixed communication about wearing masks at that time. I don't know if you remember the WHO, they changed the recommendation, which was quite interesting. And then around April 2nd, one of my friends posted a Hong Kong news article. You can see here, and it says, you know, European countries are finally starting to encourage their citizens to wear masks. So that's kind of an interesting segue into wearing masks in the US, and kind of shows some cultural differences, which we're going to hear about in a little bit from some special guest speakers. But one of the things that I was thinking about in this after spring break, when that was extended and I was teaching a lab course. So I had to figure out, how are we going to teach a lab online? You know, we were originally going to be going out into the field collecting diatoms and water samples. So what do? So I contacted a company that produced these simulations for biological learning. Like, we went through a scientific method simulation, and I asked, do you have anything for COVID-19 that we could possibly use? And they said, yes, we do have an epidemiology module. So I said, great, let's take a look at it. So I took a look at it and said, this is something that the students could work on. So what we're going to talk about now is really the basis for those simulations, which is this basic model that, remember, these models are very simplified versions of reality. They're not a crystal ball that's saying this is what's going to happen, you know, but they do help us when we're making policy decisions and just understanding the basics of diseases. So this is called the SIR model, and it's susceptible, infectious, and recovered. So we have three categories of people: when they're susceptible, when they're infectious, and then when they're recovered. So there's some assumptions to this model. It's a simple model. And one of the assumptions at the beginning, when you're starting to run the model, is that everybody is susceptible. Like Barbara had mentioned, the R naught is when everybody is susceptible. And in the SIR model as well, there's a closed population size. So there's no demographics involved in an SIR model. So the same number that start is going to be with us at the end. And so the transmission rates in between, you know, what's the rate of, you know, time that I'm susceptible and I am exposed, when do I become infectious? These are calculated through simple differential equations. So that's how we move through these different categories in a sickness. So, and then also they assume in these models that the population is well mixed. Everybody has an equal chance of meeting up with somebody who's infectious. So that's what that means, that everybody's well mixed. There's no, you know, more people going to work at the hospital or work at Kroger's. We all have an equal chance of running into each other. And then in this last category, the recovered, that means that everybody, once they're recovered, they're immune, which we know in reality doesn't happen. We lose people along the way in these diseases. So what we're going to do now is we're going to take a look at the SIR model simulation that we ran. And this is the Simutext module. And there's lots of examples that you might look up online to see about model simulations. But this one in particular, what I did was, you can see on the left-hand side, everybody's in the white color, which means they're all susceptible. And then orange is infected and green is recovered. So when you hit the start and you run this simulation, and I ran this one for 85 days, and we had an S, which is the number of people that were susceptible in this model, was 200, with a beta, which is the transmission probability. If you run into an infectious person, there's like a 0.2% chance that you might, you know, catch that disease. And the length of infection is 4 days. So you can see from this model that after 85 days, the proportion of the population that had contracted and recovered from the infection is 65%. So that's what these parameters that ran for 85 days. And keep in mind, 200 is, if you look at these parameters that we can select here, that's a fairly, it's not a very dense population. So it's about looking like a city like Columbus. So let's say this is Columbus. So what we're going to do next is we're going to look at a simulation. Oh, and also note that the orange curve we see here, that's the number of infections per day. So that's that curve that we're used to looking at when we're looking at flattening the curve. And then the white, of course, these are the susceptible. So you can see that decreases, and then the recovered, which increases. So we're going to look at an example that has a higher density population per the same area. And we're going to be looking at an example like this is New York, let's say. So the same parameters except for the population density, which is 500 now, which is more than double the 200 population size we just looked at. So we're starting this day 0. We have one person who's been injected with our virus, and then we let the simulation run. And then this time I was watching for the day when the highest proportion of people were infected. And so after day 35, 98% of the population was already infected and recovered. So you can see that when you increase that population density, the speed of this particular model, predicts that the disease will infect a greater proportion of the population and at a faster rate. Okay, so keep in mind all the parameters that we have, the S and the transmission rate and the length of our disease is all the same. Let's take a look at these. I ran these two models again, and I stopped at 40 days just to compare the low and the high density scenarios. So after 40 days, you can see on the top, this is our low density model. And at that time, after 35 days, 52% of the population have recovered. So that means they had been infected as well. And then at the bottom in the high density situation, 98% on day 40 had already reached the highest proportion. So you can see that density really matters. So the social distancing, it really does have an impact when you look at these even simple models as they're run. So in the next slide, we're going to talk about modified behavior, like Professor Anderek mentioned to us earlier, washing your hands, and I mentioned the mask. So let's say we have this hypothetical situation on the left where nobody's following, everything's as usual, right? We're washing our hands, but not very frequently and all that. We don't have any PPE, and our population, susceptible population, is 500. Our transmission rate, I kept this the same as our previous examples, so because we're not changing anything. But in the scenario where we have increased our hand washing and we're wearing masks and personal protective equipment, we've actually cut the transmission rate in half by doing this, by changing our behavior. So let's look at what happened after 35 days. We can see that again, with no change in behavior, 98% of the population have recovered. And then in the model on the right where we did modify our behavior, 65%. So we've cut that transmission rate in half, which is making a huge difference. So these behavioral things that we've been learning over the last couple months really do make a difference. And the models do show us that. So there's another model called the SEIR model, which is slightly more complex because it's adding another category of person, and it's the exposed. So diseases have a latent period. And, we don't know exactly how long we're asymptomatic, exactly how long we are, shedding the virus, how long we are exposing other people to, and transferring the disease. So, for policy making, it's really important to have a lot of data, first of all, like Barbara mentioned, in order to get more accurate model results, right? So the longer we have information and the more we understand the biology of this disease, the better our model results are going to be, right? So in the SEIR model, we also have a unidirectional direction, which means you go from susceptible and end up in recover, but we also have demographics in this model where we have births, births babies are susceptible. We have deaths when people are susceptible in a normal day-to-day life, and we have death throughout, even those that aren't, infected by a disease. So that's taken into account for in this model. And you can see that over time, that's what we're predicting. The numbers are going to fluctuate based on time. So our categories of people are going to change as time goes along. And so, these can get very complex. We can use deterministic, a way of modeling using differential equations like the SIR model, or we can use more complex random frameworks, something like a Monte Carlo simulation or a random walk where we add a lot of random probability. So a person starts here but may end up, way different from the second person. So, these models can get very complex. So this is just to kind of give you the framework and knowledge about these categories that are in these epidemiological models. So, okay, so the students, they had that assignment for week 1. There was still 2 more weeks of class, and I was thinking, okay, now, this is really interesting, this epidemiology. What am I going to have the students do for the last 2 weeks of their learning, right? And so I was doing some reading and I saw this really interesting information about different countries. So this is from an article by the Times, and you can see that this is the number, these charts are showing us the number of infections, number of confirmed cases of COVID-19. Okay, so I took out some of the countries, but just to show you, the ones in red are Western countries. And then if you look on the right, there's a couple of Asian countries. So it piqued my curiosity looking at the huge differences in the numbers. And, logically, South Korea is much closer to China, so they should have had a worse scenario, right? And Singapore as well, because they're going to be receiving more, passengers from China and everything. They're just more connected because they're in the same region. But why was it that in Singapore, the total number of cases about April 1st was 150 versus 35,000, it looks like, about 30,000 in the US. So what exactly makes the difference? What were, that piqued my curiosity. So I said, what will be really neat is to let the students have the world be their lab, right? So we're stuck at home, we can't go anywhere, we can't go out and do our sampling. So let's use the internet to do some research and learn about some different countries and what are the responses of these countries to COVID-19. So we had 7 groups, and we had a group that looked at South Korea, Taiwan, Hong Kong, Singapore, India, Nigeria, Brazil, and Spain and Italy. And I didn't choose the US because we are living it every day. We're hyper aware of what's going on here, right? So I wanted the students to kind of look at some questions, like things like, what are the vulnerable populations in your country? And what is being done to, help these populations of vulnerable people? And what is the historical context? Like we heard on Monday, some of us that were at the talk, what is the history of this country with diseases? How have they built an infrastructure or been able to respond because of some other reason, like they have a stockpile of PPE, different things like that. And also, what is the cultural difference? What are some of the behavioral differences? And then how do their measures and their ways of responding to the disease compare and contrast to those of the US? So I really wanted the students to answer some of these questions. So first of all, and I'm very excited that I have 3 of my students from Biology 122, the lab, and they have so graciously agreed to give us a little synopsis of what they learned. And so first of all, I have Chloe Hunt. She's a sophomore and she's a zoology major, and she has a social justice minor. And we're very excited to have her, and she's going to be talking about South Korea and what she learned about South Korea's response. So Chloe, I'm going to turn it over to you and let you talk with us a little bit about South Korea.
Thank you, Dr. Fair. I wanted to start by talking about that South Korea did have an experience with MERS. So they had more policies in place when they started this. But I had 4 main things that I really thought were interesting about South Korea. And starting with that was mask buying and wearing in South Korea. So in a poll done of 18-year-olds and older in South Korea, about 19% of them said that they wore masks before the coronavirus outbreak if they were feeling sick in any way. So if they had a cold or just weren't feeling well that day, they would just wear a mask when they were going out just to prevent anyone else from getting sick, which is just something that's not very well seen in the US. That's not something that I've ever had an experience with, seeing someone like that, unless in like a hospital setting. Among that, masks and PPE are not running out in South Korea as they are here. but there are strict rules on when you can buy masks. So South Korea has implemented that you can buy masks in pharmacies, but on Mondays, people born in a year that ended in 1 or 6 can buy masks. And there's a limit of 2 masks per person. And on Tuesdays, if you were born in a year ending in 2 or 7, you can buy a mask, and continuing on throughout the week. And Saturdays, anyone can buy a mask if you didn't have the opportunity to on your correct day of the week. Along with that was the way that they're testing. So South Korea implemented mass testing at the beginning of this, and they're doing it through negative pressure rooms. So they're testing, they have drive up and walk up rooms to be testing, and they are actually having these samples done through PCR testing, and they're preventing the spread of these samples coming outside the room through these negative pressure rooms, which prevents the particles from spreading. They're also doing a type of tracking. So something that would violate privacy in the US is actually being used in South Korea, and this came from MERS. And so they are doing a sort of app tracking for anyone entering the country. So they did not close their borders, but as you come into the country, you are required to download this app. And on the app, it tracks your location to make sure that you're staying home, and you are required to self-quarantine for 14 days. On the app, you have to submit twice a day what your symptoms are and how you're feeling, and to make sure that you're not spiking a fever or not having a cough. And then after the 14 days, it just tells you that you can delete the app. And I actually got these pictures from a student who was actually a student at OWU, and he lived down the hall from me this year, and he is in South Korea now, as that is his home country. And so I had the opportunity to reach out to him for these pictures of what the app looked like, and he luckily translated it for us so that we can read it. But they are doing that, as well as they're tracking people's phones, as well as their credit cards, and all the transportation that they took if they show symptoms and test positive for coronavirus. So if they're testing positive for COVID-19, they can track back where they were, and they can go through who else was there at the same time or in a similar time frame, and then they send text messages to these people who were also there to say that they may have been in contact with someone who had this coronavirus. Now, that is something that is not done here at all, and there was a lot of talk in the news about the issues that could have if we tried to implement that here because of the privacy policies. But it seems to be working very well in order to let people know that they may have been infected way before they would ever know. So along with that, South Korea is actually in the process of voting right now. So just as we would be voting in all of these Democratic primaries, and we are not doing that in a lot of states, South Korea is voting, and they're voting in person. And they are having people hand out, like staff handing out these ballots to people. They are wearing full PPE and are protecting themselves. And the people who are coming to this are wearing masks, but they're handed a ballot, and they just walk up to the booths. The booths are outside to prevent the spread of infection further, and they must be a meter apart. But it seems to be working because this is the highest voter turnout that they've had in 16 years. So that's what I found most interesting in my research about South Korea.
Wow, every time I hear my students give these brief talks about what they found out, I'm just amazed and very proud of what they've done. And I just, hope that everyone in the US can do the same thing. So next, we have a couple of actually freshmen who are going to talk to us about their experience researching what's been going on in Brazil. And we have Adrian Moran. He's a freshman, and he's a biochemistry and genetics major with a Spanish minor. And S.K. Bullander, she's a freshman, and she's majoring in English literature and with a minor in environmental science. So, and we'd like to welcome them both. They're on the West Coast. So we really thank them for, joining us today. So let's see what they found out about Brazil.
Okay, thank you, Dr. Fair. So I'll start out. We researched COVID in Brazil. And one thing that I found really interesting was that because Brazil's like, they have a lot of cases, confirmed cases that are right now, but that are sort of plaguing their country right now. One thing that's interesting though is that they had really strong preventative measures when COVID was first becoming like an international crisis. Their Minister of Health actually sent out people to fetch any of the Brazilian citizens vacationing in China, especially Wuhan, and brought them back and put them in quarantine. But because their Minister of Health and their president don't really agree on sort of the like seriousness of coronavirus, because their president, he actually still denies that like coronavirus is a threat. You can see there in the bottom picture that he's attending rallies to protest social distancing measures, and he's like, one thing is that he's like kissing babies, and he's sort of like wading into the crowd and like being really touchy to sort of openly defy the social distancing measures. But this like created a lot of confusion, and so since they didn't really have a strong federal voice, a lot of the state governments were slow to sort of step up and implement preventative measures, so their cases shot up. And then another thing that I thought was really interesting is they have these neighborhoods called favelas, which are really highly high in density, population density, and they're also on the poor side. You can see there up in the upper left corner, there's that separation between a really like nice neighborhood on the right, and then on the left you can see how packed favelas are. And these people already don't have access to good health care. A lot of diseases, like endemic diseases, are still like swarming around in their population, like dengue fever and malaria. And they also don't have access to running water. So it makes like dealing with COVID really hard. But on top of that, they're also being overlooked by their government. So their government isn't doing a lot to reach out and try and help them. So it's like making it even harder to deal with it. And they're being really hard hit by coronavirus. So some really unlikely leaders have stepped up, like drug gangs have actually started to enforce social distancing. You can see in the image in the middle on the slide. That they're like patrolling streets and trying to enforce curfews and social distancing measures, like making sure people are staying 6 feet apart, or there are no like groups bigger than 2 people walking on the street at the same time. And they're like sending out text messages trying to tell people, you know, to stay home, warn them to stay home. One thing that they said was like, if the government doesn't step up, organized crime will do the job, or something like that. And then a lot of local artists are actually carrying out like educational campaigns, creating signs, you know, to educate people on personal sanitation and just how serious coronavirus is, in order to like try and combat the misinformation that the president is giving. And another thing is that there are a lot of measures that they're implementing on their own, like a lot of programs to try and combat, since these populations tend to be poor, they can't really afford to stay at home for social distancing and be unemployed. So a lot of people are stepping up to help them. Like there's one program called Adopt a Housekeeper, where the public raises money and they spread it out and distribute it among like the unemployed and give them allowances to try and help them out. And another one is that they sort of designate certain residents to be presidents and like go around and check in on the neighborhood. Yeah. Adrian, you want to take over?
Hello, I'm Adrian Moran. Thank you. What I found interesting is that Brazil is also facing a polarizing population. So even though Brazil's virus cases have exceeded China's cases, their president is still downplaying the virus, as SKS said. Regardless, the health minister previously still implemented lockdown measures. But since the president and the health minister disagreed a lot, the president has actually fired the health minister. And the public has responded by protesting on their home balconies, by banging pots and pans. The other side of the public is protesting by having rallies and protesting the lockdown, which the president himself has shown up to and joined. On top of that, Brazil is located next to the heart of the Amazon rainforest. Their government workers haven't been able to manage the protected lands so far. So deforestation has increased 51% in the protected lands in the first 3 months of 2020 through illegal logging. These illegal loggers can also be vectors and could be potentially carrying the virus deep into the Amazon and bringing the virus toward indigenous populations. And indigenous populations which are living in the Amazon, they're far from hospitals. They don't have a lot of running water or any doctors there to treat them. And one of the first deaths among the indigenous people was a 15-year-old boy from a tribe. The Amazon's upcoming dry season will be an issue as well. Last year, there were more than 2.5 times the number of people with lung problems going to the hospital because of forest fires. And if this year's dry season is just as bad, then waves of people with respiratory illnesses will be rushing towards hospitals, which are already overloaded with coronavirus patients. So Brazil is not out of the clear yet, and they still have some problems coming up. Thank you.
Okay, now this is the reason I love to teach, because you interact with these, look at these freshmen and sophomore that can go out there and learn all this, and it just shows you how much potential there is for our future. So you guys need to hurry up and graduate and get on with your careers so that we can rely on your generation. Okay, thank you very much. And like I said, that's probably much more interesting than all this modeling that we're going through. So this figure here, you can see that as Professor Anderek taught us earlier, these curves have different inflection points. So you can see that this is a logarithmic exponential increase in cases. So we see that our inflection point is shown, well, it's not shown, but you can kind of guess where it's at when comparing countries like United States, Brazil, China, and South Korea. So these are the countries that we just heard about. So it was kind of interesting that this chart had those 4 countries on it. So you can see that it looks like the United States is possibly going towards R value of 1, but Brazil looks like, their trajectory looks a little bit more precarious here. And then you can see South Korea is pretty much leveled out. So, they've probably already passed their inflection point for now, that is approximately an R of 1. So how are we going to go forward with all this? We don't have a vaccination, but one of the things when we do have a vaccination is that we are going to aim to develop this herd immunity, is what it's called. So that's when enough people are immune from a disease that it protects the entire population. So what we're really doing when we're getting vaccinated is we're protecting the populations, the young people, the babies, and the elderly, and people with secondary underlying health issues. So those are the people that may not be able to withstand being vaccinated, but if the rest of us get vaccinated, then we can protect the entire population, including ourselves. So there have been some vaccination programs around the world, and of course, a couple of very well-known ones are smallpox and measles. And smallpox has pretty much been eradicated due to vaccination programs. The most recent, outbreaks were in Africa, and then the disease was eradicated in 1979. The certificate was issued that it was eradicated. And you can see in this chart in the lower left-hand side that smallpox, now remember, this is based on the R0, and it's a historical R0 value. And, different research groups might, estimate different R0s, and based on the location of where, disease occurs, the R0 could be different as well. Because remember, it could be based on a local population, such as if disease hits a favela in Brazil that's very densely populated, poor people, no running water, the R0 within that enclosed population is going to be much, higher potentially than in Columbus, Ohio. So that's something to keep in mind. And measles has an even higher estimated theoretical R0 value of 12. So you can see that the vaccination proportion is much higher for measles than for smallpox. And if you look at the chart on the right, you'll notice that historically, before vaccination was developed, we had terrible outbreaks of measles. And then as soon as the vaccination, well, a lag of many years, but we pretty much, almost eradicated measles, but it keeps coming back in these waves. And a lot of college students know they probably have recently had an measles, mumps, and rubella vaccination boost if they didn't have their certificate showing that they were immune from the measles. So, and there have been studies that have estimated R naught as high as 203. There's a huge range. So, but just keep in mind that that's a theoretical value, could be different in different locations based on, all these population characteristics. So, but the whole goal of vaccination programs is to reduce the effective R, or the RT, R over time. So that's what we're doing as we're building up our immunity to a disease. And how do we calculate this critical minimum level or minimum proportion of the population that should be vaccinated in order to develop herd immunity to protect all of us? And this chart shows you that based on the R naught, we can pretty much calculate a baseline value that we target for. Like, for example, if our R naught was estimated at 3, we would calculate that about 67% of the population should be vaccinated in order to develop this herd immunity. And you can see that that would increase with the R naught of the disease. So, but that's our baseline level. Say, this is the minimum amount. It's better to get more, the more immunity, the better for the entire population. So that's the way you can actually calculate herd immunity, basic calculation. Okay, so now I'm going to turn the presentation over to Professor Anderek. Again, she's found some interesting information on herd immunity by country.
In the interest of time, I think I'm going to skip the next few slides. There's some nice information there, but I think so that we have some time for questions, I'm going to skip on, and I'll let you stop at the next slide. Thank you. Oh, nope, previous one. Just a little bit here to say that it's very difficult to know where we're going from here. We would love to know what's going to happen next, but here is a report done by a center that specializes on this kind of research, and they have 3 different scenarios. You can tell from the look of these graphs that they're just like hand-drawn kinds of graphs. They're not models, they're not projections, they don't have that level of detail. They're just different scenarios that could happen. All of that to say that even with lots of expertise, it's very hard to know because there's so many variables that are going to affect what that R value is going to be from day to day and week to week. And so we really don't have a good idea of where we're going from here. But in summary, we want you to have a few takeaways from what we've talked about today. You can model disease spread, but if you're going to do that, you have to be careful about what kind of model you use. The ones we presented were very simple, but the ones that are used to make predictions that are being used by the experts really involve lots of pieces. They have to be tested. They've been tested against historical data to be sure that they're robust and that they work. They have to have enough data as inputs, and that data has to be reliable. It would be nice if it were the same from one region to another, one country, one state to another, but we know that the conditions are very different, the amount of testing and so on. We have to know what kind of assumptions go in because that affects what kind of results come out. And there's lots of, as we heard from these wonderfully articulate students, there's lots of local conditions that are going to affect the way things move forward. And sometimes those conditions can be put into models, and sometimes we just see the effects on the other side. Finally, what we are experiencing continually changes, and the models then have to continually change as well. So thank you very much for attending, and we'll try to answer a few questions if we have time.
Thank you so much to our presenters, students included. So we do have a couple of questions from the audience. The first one is for Dr. Fair. What interested you and the students about the countries you chose for that project? Are there other countries that you think would also be interesting to examine?
Oh yes, if I had, you know, double the number of students, we would have done double the number of countries. But I tried to hit like some of the countries, for example, like Nigeria. I chose that because I saw some information that was occurring in the news, and I knew that like Nigeria has a lot of ties with China and China business. So I thought that was interesting. They had some history about, you know, dealing with diseases and immigrants. And India was a very interesting case study, which, you know, we had students do, and what's happening there is really not what we thought would happen. We thought that there'd be horrendous outbreaks, but come to hear, you know, in the news recently, they're kind of puzzled as to why there aren't these huge outbreaks in India, and it could be the population is skewed much younger, you know. So, but as far as other countries, you know, it would have been wonderful to hit, you know, some countries in the Middle East, for example, countries that are affected by things like the Hajj. You know, you think of these mass migrations of people to, you know, on these journeys for their religion. Would have definitely been super interesting, but we just had a limited number of countries, and I definitely wanted them to see the different Asian countries, because, you know, that really contrasted with some of these, the Brazil and Spain, Italy was an interesting talk as well. I mean, so ideally we do them all.
Thank you.
Thank you.
So in modeling, what is an appropriate unit of population? How do models take into account clusters like in prisons or long-term care facilities?
Well, I don't know the specifics of how they take care of that. I think sometimes the models are simulations where they're sort of following trajectories about where people go and who all they interact with. That's those stochastic models that Heather referred to. So that might be one way to take those into account. Sometimes I think they're just not able to, because that's at a fine enough scale that they have to treat things more globally. Globally, I don't necessarily mean the whole world, but maybe the whole state of Ohio, or maybe you're looking at rural versus urban, but you're not breaking it down till you get to that place that we're talking about, a particular facility. I suspect that there are models that would apply within facilities, whether it's nursing facilities or whether it's correctional facilities, but those would be done separately, just related to a particular facility. That's my assumption. I don't have the expertise myself, but that's how I would guess that those are handled.
Great, thank you. And this last question is kind of combining a whole conversation that was happening over here in the chat throughout. People were having a really fascinating conversation about how these numbers get reported in the media, and how there doesn't seem to be a consistent way to report numbers. So sometimes we see media outlets or governments reporting absolute number of cases and deaths. Sometimes it's ratios or percentages, but all of this makes it really hard to compare across different places and times. And so our audience has been discussing, and I'd like for you all to chime in on what you think is the most appropriate way to report data like this to the public. Should we be using absolute numbers, percentages, a combination, something else entirely? And should everyone be reporting this kind of data to the public in a similar way to help us make better sense of it?
My feeling on that is it would help to have some consistency, even if it's just consistency within a particular, you know, so if you watch the same news from one day to the next, at least if they would present things consistently from one day to the next, that would be helpful. I mean, it's helpful to see things from different perspectives, but there's enough going on there that it can be very confusing, which is why I was trying to give some warnings about how you interpret what you're looking at. I think if we kept talking about things in the same way, that's why I referred to the BBC, because they keep talking about the R value, and if that has meaning to people, even if it's presented in different ways and it's at different points on a graph, that at least has some meaning to the population because it's been discussed consistently. So I think consistency is a big point. I don't know whether there's a best way to do it, but I will say that often in watching US news, even NPR, let's say, well, I wouldn't be watching NPR, but PBS, let's say, I keep wanting them to put some kind of graph up, and they tend to be just talking and not doing much in the way of the visuals. So I have no solution, but I think consistency is important, or else we're just confusing people.
All right, well, thank you very much. And I did want to note that the audience was very impressed with the students and are interested to learn more about what they learned. So I know that Chloe has already posted that she can put a recap of the research she's done in a PowerPoint to the Facebook group. So if any of the other students want to do that as well, we would really love to see that. So I want to thank Dr. Anderek and Dr. Fair for sharing your time and knowledge with us, and a big thank you to the students who joined this presentation. You all did a fantastic job. And thank you, as always, to our audience for joining us and asking excellent questions. Don't forget that you can continue your conversations on the Facebook group. And another way to continue the conversation is the Meet the Professor sessions. Students who have registered for the course can join us tomorrow at 4 p.m. in Blackboard Collaborate. Community members can join us at noon on Friday in Blackboard Collaborate. The RSVP links will be sent in an email, but if you have questions at any time, please contact COVID Course Coordinator at owu.edu. See you again soon.